So I'll be talking about radiation. You know, it's not as attractive or as, I would say, sexy as talking about TAVR or doing a CTO or a bifurcation. But trust me, all of us deal with radiation. Even if you're doing a CTO or you're doing a TAVR, this is something that we'll be spending all of our lives dealing with. So there are different kinds of radiation. So what do you need to know about it? You need to know quick ABC of the X-ray, occupational risk in cath lab, radiation safety basics, and optimizing the radiation in the cath lab. So there are three types of radiation: alpha, beta, and gamma. So gamma is the one that we are more interested in because this is the one that can penetrate through the body. Alpha and beta cannot, but gamma cannot penetrate through the lead, and that's what our savior is. This is a kind of a standard cath lab model all of us are familiar with. This is an II image intensifier. This is the tube where the radiation is produced. Then you have the table and the monitors. So how do we get the radiation? Basically, it's the scatter radiation. What happens is X-ray tube produces the radiation. It goes through the patient and gets scattered and gets exposed to the operator or the staff that is present in the cath lab. There are different terms all of us should be a little bit familiar with. The abbreviation is READ, that's radiation exposure absorbed dose and dose equivalent. Basically, exposure is coulombs per kilogram and biological effect is in sievert and absorbed dose in grays. So how does gray is different from sievert? So sievert is similar to gray, but it takes into effect the potential ability of the radiation to cause a biological effect. Now, what is that biological effect? I'll allude to it in a few minutes. This is a very popular diagram, or you can say the table that everybody shows in their talks on radiation. So you could see a chest X-ray is 0.02 millisievert, while a regular coronary angiogram is about 5 to 7 millisieverts. That's about 350 X-rays. And dilating a CTO is about 81 millisieverts. Doing a thallium scan is about 6 to 9 millisieverts. CT angiograms are 15 millisieverts. So that gives you a good perspective what we are dealing with all day long, that one angiogram, the patient gets exposed to 350 chest X-rays. So one interventional procedure is equal to 250 to 350 chest X-rays, and as interventional cardiologist, and I can assure you after Cath card, we may be the most exposed to the radiation people in the whole world at this point here in Pakistan. And the worst thing about radiation is that you don't feel a thing. If you get a nail in your foot, you'll be running to a doctor, or if you get something in your eye, but radiation, you can be standing there all day in cath lab without wearing a lead, and you're not going to feel anything by the end of the day. It does not cause any pain at that time. So that's what makes it the most scary part. What does it do? It causes two types of effects. One is called deterministic effect. The other is called stochastic effect. Deterministic effects are dose relationship. They happen, if not immediately, maybe in a month's time, 6 months' time. That results in hair loss, skin damage, tissue necrosis, cataracts, sterility, decreased WBC. Stochastic or probabilistic effects are cancer or genetic effects. So I'll give you some examples. So this is an example of deterministic effect. So this happened to a patient who received about 11 grays. That was the calculated peak skin dose, and that happened after a month. So if somebody received 18 grays, this is a patient happened at 6 months, the skin necrosis. So these are all deterministic skin effects. So in outside countries, if a patient has more than 4 grays of radiation exposure, it's a sentinel event. The nurse would call the patient every week to ask how they are doing. Stochastic effects are the ones that is usually causes cancer. So you get exposed to the radiation, it causes cancer cells, and it takes several months or maybe years or decades for it to develop over there. These are few numbers that all of us are get exposed to at the end of our procedure. Most of our screens would show this number. One is fluoroscopy time, one is air karma, and one is DAP, which is dose area product. So what is a fluoroscopy time? Fluoroscopy time kind of underestimates the total radiation dose received, but because it does not put into effect the cine that we have used, and we know that that has a more radiation exposure. Now, air karma is the one that shows us about the deterministic skin effects, and DAP tells us about the stochastic effects of the thing. So a few basic radiation protection principles. Number one is justification. Number two, ALARA. Number three, we need to be familiar with dose limits. Justification. So all of us should follow the guidelines. You know, if the procedure is indicated or not, we should use the appropriateness criteria before committing to the procedure. And ALARA principle is always used in the cath lab as low as reasonably achieved that we can. And then these are the doses, these are the total limits that we should be familiar with. That's 30 millisieverts per maximum per year for a physician, or 20 millisieverts if you average over 5 years. So 100 in 5 years or 30 per year. 500 millisieverts for the whole body for the skin, and 150 millisieverts for the cataract. And the main thing that you need to consider is radiation, distance, and shielding. So how do we optimize it in the cath lab? First thing, you need to be familiar with it. If you're not familiar with the radiation, we need new nurses come in. They're not even if they're not wearing a lead, they'll still be, the physician is pressing on the paddle and they're still there. So you need to be familiarized, hey, there is a radiation going on. Number two, badges. So badges are very important, your dosimetry badges that I'm alluding to. They give you absorbed dose, they give you equivalent dose, they give you effective dose. And all of them kind of show a different factor about the radiation exposure. Ideally, you should have two badges, one above and one underneath the lead. And they would allow you to tell you about the one outside deterministic effect, and the one underneath the lead would tell you about the stochastic effect. And they should be checked every month, whatever is the protocol at your institution. Now, these are certain monitors that I have yet to see, not here, even in USA or even here. They are real-time radiation dose monitors that are in the cath lab. They enable the staff to see their level of exposure. That is, they would tell after each procedure that how much you are exposed to. I think they'll come in very handy, but I've yet to see one here. Now, very practical point here about SID, subject image distance. You want to have a low SID. Low SID is when the patient is closer to image intensifier, far away from the tube. So you see the dose here is 1 unit when you have 80 centimeter versus 30 centimeter. And then here the radiation dose is 1.4 dose per unit when you have the image intensifier closer to the patient and the patient closer to the tube. And then the dose is 2.6 dose units when you could see the distance is 60 centimeter and 50 centimeter. And we see this very often when you have a fat patient or a big, thick patient. What we have done is they decrease the table height. They take it closer to the X-ray tube, which is wrong. It should be the other way around. You should get the table all the way up to the II, away from the tube. That is when you get the lowest possible radiation. So that makes a big difference because you'll have the less radiation exposure at that time. Again, minimizing the angulation is important. All of us have to do angiograms. We have to do certain angulations to open up the arteries or the bifurcations. But you could see here, if you have an AP position, it's 20 to 40 milligrams per minute, while if you put patient in a LA or RAO cranial position or LA or AP cranial, it goes exponentially 10 times more, 252 milligrams per minute. Now, FOV, very important. This is when your technician kind of focuses on things and magnifies things. So if you have a FOV, sorry about that. So if you have a FOV which is 25 centimeter, which is like a big FOV over here, the dose would be 0.3 milligrams per second. Now, if you have a FOV of 17 centimeter, that is the dose doubles up. If you have a FOV of 12 centimeter, that's a very thin slit that we are looking at them and they're magnifying the images, the dose rate goes exponentially high, about 4 times that. So the FOV definitely will decrease and the dose delivered to the patient's skin will increase in this case. Collimators, you need to know your collimator. What is a collimator? It's a lead shutter. It's present next to the beam exit port of the X-ray. So look at this picture over here. There are no collimators. We don't need to look at the lung tissue. We're not doing any chest X-rays over there. And you would see that lung tissue would burn. So if when you ask the technician to bring in the collimators, when it looks at the collimators, you could see the collimated bone would kind of focus right on the heart. And you will have a much better picture and look at the anatomy. Skin dose fluoroscopy, again, very important. It's more important that you ask the technician to move the II very frequently. So this is a patient which gets exposed for 30 minutes. It's 1500 milligauss when the X-ray beam was not moved. Now the same 1500 milligauss when the X-ray beam was moved 15 minutes here, 10 minutes there, 5 minutes there, it makes a big difference, especially in the deterministic skin effects when the patient have the skin effects. So it's very important that you spread the dose. Pulse fluoroscopy, again, most of our cath labs in Pakistan uses 7.5 frames. You'll be surprised in America, it's 10 to 15 frames for the most part for coronary angiography, and LV grams is 30 frames. So it makes a big difference. It decreases from going from 15 to 7.5 frame, the radiation exposure by about 67%. So this is very important. Again, position of the II and how you stand is very important, whether you lean on the patient or not. And this is very important for our electrophysiologist friends who are doing pacemakers and in the left lateral position. So this is a left lateral position. You could see the patient is standing here and the doctor is getting 8 milligauss per hour. As compared to when you are in an AP position, then most of your body is getting exposed to 8 milligauss per year. So left lateral position is very bad. If you have to use left lateral position, you rather have a shield present next to you. That's very, very important, and that the shield should be present next to you. Again, heavy foot syndrome, all of us are familiar with it. You really have to let go the sign angiogram. Where you don't need it, you just do last image hold or do fluoroscopy save. Most of the machines have that. just keep on pressing it for a longer period of time while the balloon is moving does not make it any better. You need to know your, I would say, Zara Bakhtar, a lot of our army friends are here. You need to know your lead apron, protective cap, thyroid collar. You need to know your shields. They're very important. The one that's mounted from the ceiling, the one underneath the table. Most of these cath labs have about this much because it's all kind of eaten up here. Again, make sure you take care of your lead. If it gets piled up like this, it will get cracked up. It has to be hanging like this to make sure that it stays and does not get cracked up. Core path is coming. It's already there. EP people use it across the board. So I think it's a very important thing that we take care of all of these things. This is the last slide. Now, let's say if you were to sleep through all of my talk, if you just give attention to this last 1 minute, it would give, this is the summary of it. So avoid heavy foot. Where you don't need cine angiogram, just do last image hold. It'll make a big difference to your radiation dose. Minimize AP and LAO cranial. Do it if absolutely you have to. Minimize your FOVs or minimize your magnification modes. Use 7.5 frames of fluoroscopy. Keep the patient closer to the II, and then use the collimators. And then definitely monitor your radiation dose. That's very important. And then take care of your lead garments. Make sure if you don't have to stay close to the patient, if you have a fellow that is standing next to you, just make sure he stands between you and the patient. He can take the radiation if you don't have to. And make sure all of your shields are in optimal position. Thank you very much for your time and attention.